four prominent experts that I will introduce in a moment. Professors Van Dam, Professor Lisa Lin, Professor Heidi Larsson, and Professor Anna Antich. So first of all, and thank you all for joining. We hope to have a significant global health and beyond audience. So it is an opportunity to very briefly introduce you to what is EGHRIN. EGHRIN, the European Global Health Research Institute Network, unites 23 European global health research institutions and also some associated members throughout Europe, about 10 countries right now, joining forces to enhance awareness of global health aims and themes, to strengthen excellence in global health research and education, and to also achieve impact on EU's global health research agenda, and also trying to contribute to the translation of the key research finding in this area into policy implementation and practice. And we work jointly with other research and education European networks like LERU, the League of European Research Universities, or the European University Hospitals Alliance, among others. For more information, please check our website, which is now under revision. So the main aim of this EGHRIN series is to try to contribute to build awareness about some of our initiatives at EGHRIN, and the issue of pandemic preparedness is an issue where we have been involved, of course, as many of you in recent years, both in terms of introducing this as a key research area, but also in terms of providing some thinking beyond somehow the usual levels of the discussion of preparedness. And we are also following very closely the recent formulation of the EU Global Health Strategy, where, as you know, one of the three main priorities that have been defined includes combating health threats, including pandemics. So the way this is going to work, if I may have the next slide, Alberto, very briefly, we will have three brief, about 10 minutes interventions from our speakers, and then I will ask each of them one question, and then we'll open the discussion to all the audience. Let me say that in the questions and answers section, you are all the audience is very much welcome to contribute to the questions, and if you have specific panelists that you want to answer that question, please indicate that. And that also there'll be the opportunity to follow up on some of your opinions that you can write down in the chat box, and through contacting our secretariat, Alberto Rocamora. And I will just close this whole introduction by saying that after this webinar, we are thinking of preparing what we've called provisionally a position note that will bring together while we summarize the main contributions of this debate, and hopefully be able to follow on that as part of our network effort. So thank you all of you for all your contributions here today. Let me therefore introduce our first speaker, Professor Annemieke Van Dam. She's a biochemist with a PhD in sciences and full professor at the Faculty of Medicine, University of Leuven in Belgium. She joined the Rega Institute for Medical Research, where she started a unit on virus genetic testing for clinical practice. She co-founded a new division on clinical and epidemiological virology. And in 2016, she started she co-started the Institute for the Future, a transdisciplinary research incubator. And she is also an invited professor at the Institute for Hygiene and Tropical Medicine in Lisbon, where she's physically right now here today. And Moreover, she's been a little bit the soul of this initiative, of this webinar. Thank you very much, Anne, and Emike, for all the work that you've put into preparing this. So over to you. We cannot hear you. You are muted. You are still muted.
And
okay.
Me now? Okay.
Yeah.
So thank you, Tony. Are you seeing my screen?
We are. Yes, we are seeing fine.
Wait, I have to go back because I need to go to the first slide. Yeah. So thank you for this nice introduction, and also thank you to EGHRIN to give me the opportunity to co-create this position note together with the other speakers and with all of you present here today. So this is going to be a co-creation event. We want your input, so please write in the chat what do you think, and we can consider that when writing the position paper. So I'm going to talk about 7 pandemic preparedness goals, which are the lessons that we learned from the COVID-19 pandemic in Belgium. So we might be fed up with talking about the pandemic. So some people really don't want to talk about it anymore. But if you see these messages about H5N1 starting to get spread among some outbreaks among mammals, we know that some of you are getting worried. As you see, the scientists are also getting worried about a potential H5N1 flu outbreak among humans. And this is not, if this is the case, of course, we are safe right now because there are no human outbreaks. We don't know if it will become a pandemic, but if it becomes a pandemic, it's not going to be like COVID-19. This is a mortality in sporadic cases was about 60%. So just to let you know that even no matter how much we try, pandemics are inevitable. And the question is, from our lessons that we are learning from COVID-19, are we now better prepared? Now, the Global Preparedness Monitoring Board stressed that right now we might in some aspects be better prepared, and other aspects less well prepared. So if you see the last message here, can we expect a different outcome to the next global health crisis? They say no. So what is it that we have to learn? In Belgium, we set up a learning project in February 2020. So that was after WHO announced a public health emergency of international concern, which is the highest level of concern that they can issue. And before we really tumbled into the pandemic. And what we wanted to do with this project is to approach pandemic preparedness as a wicked problem. So having not seeing it as a problem that can be solved, but seeing it as a mix of interrelated factors that are in many different disciplines with feedback loops and unexpected consequences of actions that you take. So you have to look at it in a systems view. So that's what we set out to do. And to do that, we need a transdisciplinary approach. So I think you're not seeing this properly. A transdisciplinary approach is focused around problem solving, and it's also collaborating between different disciplines and academic institutions with other societal actors. So we did that in our project, and I'm not going to go into detail, but we worked for 2 years. We had several teams, and just as an example, we had a politician in our team, we had a social media person, we had an entrepreneur. So the diversity, psychologists, sociologists, medicine, the diversity of our team was big. We had a student team also, with students from medical sciences, philosophy, in business engineering, and the second year we added people from law, from education, from economy, and then we also had a second year student team, again with students from different disciplines, and a third year student team that is currently still working with people from ethics, medicine. Just to say that we are trying in this project to build a broader view on pandemic preparedness. And the method that we are using is we start with problem framing, and we explicitly wanted to learn from this pandemic to be better prepared for the next pandemic. Then we try to understand the complexity, build systems knowledge in many different ways. Then we engage with multiple stakeholders to co-create, like in a webinar like this one, the views of the different stakeholders on the complexity and also on the futures, trying to imagine a future where what would be the ideal pandemic preparedness and how to get from where we are to where we want to be. So in the end, we came up with 27 lessons learned from the Belgian pandemic. So there must be many more lessons learned if you look at other areas also. And there were like 3 categories of lessons. The first was like general lessons to improve societal sustainability. And I will just briefly give one example. Adopt the whole of society approach for a whole of society phenomenon, because a pandemic is a societal crisis. And others have been doing research in the same way, looking at the multidimensionality of pandemic preparedness and the resilience in pandemics. So you see at country level, at regional level, at mixed level, there are many different factors that are important. Now, the second set of lessons are lessons that can apply to any crisis. And I'm just picking one of these lessons here: improve and professionalize communication, because communication can build or break trust, especially in complex and risky situations and in times of great uncertainty. And I'm just having a quote here of someone, one of our stakeholders in the stakeholder listening that we did. I'm putting it in English. The communication in Belgium at this time, which was the first wave, is a mix of Kafka, Monty Python, and comedy capers, a cacophony that is confusing everyone. It improved in later waves, but basically a lot of trust was lost because of this in the first wave. Now, a third category of lessons is how to be prepared for a pandemic specifically. And again, only one example of these lessons: implement previously learned lessons. It's not the first pandemic that we are going through, and writing down lessons is not going to improve pandemic preparedness. So like Laurie Garrett said recently in Deep State Radio, pandemic preparedness lessons are not to put in drawers and put away after a pandemic happened. So one way we thought this could happen is to transform them into pandemic preparedness goals, similar as what is done with the Sustainable Development Goals. So that's what we did. We clustered our lessons in categories, And we came up with 7 categories, and I'm going to just take one example from each category. So let's take the first category, which is prepare to limit the spread of a pandemic pathogen, which is the very classical way of pandemic preparedness. And one of the targets there was improve host resistance, and this includes non-pharmaceutical interventions. So the lesson that we learned in Belgium, that we need to be better prepared to quickly roll out containment strategies, especially the test, trace, and isolate strategy in the very, very beginning of the pandemic, lacked coordination. There was a lot of knowledge in Belgium about this because we had very well working tuberculosis test, trace, isolation strategies. And these were kind of relearned during the first wave. We could have been doing it much faster. The second cluster of lessons, we came to pandemic preparedness goal 2, health care to include the entire human being, which means body, mind, and social relationships. So this came from the observation that during the lockdown, there was, especially in care homes, there was a loss of social relations, and this affected mental and also bodily health. So attention for, not because recently body and mind is being integrated, but attention for social relationships is not sufficiently integrated right now. We need to make time for that in healthcare. Then there's another set of goals which relates to governance and society. So the next cluster is about equip governments to meet a pandemic challenge. And again, only one example here from a lesson that the advisory committees were not constructed in a transdisciplinary way. So they were too monodisciplinary, even though they thought they were interdisciplinary. There were disciplines that were not in there from the beginning, like sociology, psychology, and also the societal actors. So we thought one of the targets to equip governments to meet the pandemic challenge is to provide a framework for consulting stakeholders.
So 1 minute, Annemieke, please.
Yes. So just to say, PPG4 is prepared to maintain societal values during a pandemic. PPG5 is prepared to maintain societal functions. We also have professionalized communication and equip society with creative and adaptive capacity. So I'm in a survey of stakeholders. Better communication, better education, and limit the spread of a pandemic was seen as the most important. And here you see that we cannot deal with all these issues on their own. We cannot pick out spread of a pathogen separately because there are so many links between all the PPGs that we need to advance on all of them at the same time. Just look at trying to reduce the spread of the pathogen by improving surveillance. You see in the systems map that goes from surveillance to reduce spread of pathogen, there are many other issues that are not directly related to reducing spread of the pathogen, but to other pandemic preparedness goals. So basically what the message I want to bring is that we need to bring in these other disciplines into pandemic preparedness, but we also, from the health discipline, we need to reach out to these other networks to try to co-create pandemic preparedness together for the future. Thank you.
Thank you very much, Annemieke. We will have time for questions. So let's move on to the second block, and the second block it will be co-presented by Heidi Larsson, who for time zone reasons was unable to be here, but she recorded her presentation, and this will be complemented by the presentation of Lisa Lin. So let me introduce the two of them. Heidi Larsson is Professor of Anthropology, Risk and Decision Science, and is founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She's also clinical professor of health metrics sciences at the University of Washington, Seattle, and guest professor at the University of Antwerp in Belgium. And Lisa Lin, who will be complementing the presentation that we will just show, is co-director of the Asia Pacific lead and Behavioral and Digital Innovations lead of the Vaccine Confidence Project. She's an assistant professor at the London School of Hygiene and Tropical Medicine, working closely with Heidi Larsson, and she's the PI of various behavioral and communicational AI technology grants. So over to you, Heidi. Can you please, Alberto, activate her presentation, and then we'll move on directly to Lisa.
So if there's any problem with the sound, let me know. Okay.
Heidi Larsson, I'm really sorry to not be with you today. I'm going to say a few words and share some of our recent findings regarding to pandemic preparedness and the experience of people during the pandemic, this current pandemic, and maybe some of the ideas of what it can help us think about today. I'm very happy that my colleague Lisa Lin, Dr. Lisa Lin, can contribute to and help with the questions and answers. One of the interesting and I thought quite thoughtful reflections on the pandemic and society from Bill Gates. He writes an end-of-year letter every year with his reflections on the year. This 2 years ago in 2021, he wrote, "I'm worried more than ever that I've been about the ability of governments to get big things done. This era has shown us how declining trust in public institutions is creating tangible problems and complicating our efforts to respond to challenges. If your people don't trust you, they're not going to support major initiatives. And when a major crisis emerges, the next major crisis, they're less likely to follow the guidance necessary to weather the storm." This was a stormy COVID response at many, many levels, and we have so much to learn as we think through in the session today on preparedness and the whole of society approach. We can't have a whole of society approach without society. And in the context of COVID and the vaccine rollout and all the measures, we didn't have society on side with government in a number of countries. We did focus groups in the last few months in 6 big cities of the world: Paris, Sao Paulo, Bangkok, Abuja, Delhi, and New York, interviewing and talking to people through focus groups on what was their experience of the pandemic. And we had a bundle of emotions that came out. In Paris, it was confused, surprised, controlled, frustrated, oppressed, confined. In Bangkok, it was also fear, concern, stressed, suspicious, depressed, angry, hopeless, sad. In Abuja, frustrated, depressed, scared, fear, anger, blessed, and stressed. New York was a mix of disappointed, confused, frustrated, anxiety, hopeful, angry, fear, and isolation. Delhi, people said fear, anxiety, depressed, as we've heard in a number of other settings, but they also said happy. They also said relieved. And when we asked more about why happy, they said, we saw the sun, we saw the sky for the first time because the airplanes stopped and the pollution put its curtain down. So some people found moments of happiness, but otherwise had this shared sense of, as also in Sao Paulo, confused, frustrated, anxious, anguished, depressed. One young man in Bangkok said to us, leaders must be able to listen to others, especially experts and advisors in specialized fields. But they must also listen to the real situations and the real problems of people. We've launched an initiative called the Global Listening Project, and we've been listening to people all over the world. We're doing that now. We'll be rolling out a bigger survey to 70 countries, and that's to hear from people what their experience was, to bring to leaders the experience of people, the ideas, what worked, what didn't, who did they trust, who didn't they? Because it's only by bringing their voices together with the various expert opinions and government perspectives can we possibly have a whole of society approach. Trust was overwhelmingly a strong thread that came up again. Trust and lack of trust, trust and distrust, trust in complot, in conspiracy sometimes, and trust in vaccines on the other. So there may have been trust in different ways, but it wasn't always trust in the genuine, factful information. One of the big issues we saw, or findings, I should say, was that more than any other factor, age, education, employment, income, overall health, the biggest factor that predicted people's willingness to take a vaccine was their trust in their government and how the government handled the COVID response. So that experience, that trust experience, when it was there, it was a huge boost in people's willingness to take a vaccine. So as we think about the future, preparedness, and getting ready for the next one, we must think about how to rebuild the trust relations. We've been monitoring around the world at the Vaccine Confidence Project, a partner project with the Global Listening Project. We've seen, unfortunately, that throughout COVID, there's been a drop in public confidence in general vaccines and childhood vaccines. Somehow, the experience of COVID and the feeling of being forced to take vaccine has made people in a number of countries, not all countries, but in many countries, feeling less trustful of vaccines and more resentful of government for having pushed them into taking vaccines. And the experience was so different with different people. Everybody was willing to take guidance from government, but many of them said it didn't relate to their lives and their situations. One person told us some people definitely had it harder than others, but we still have that collective experience of the pandemic, all going through it together. But some of us were in a yacht, a big boat, and some of us were in a little.
Okay, so thank you, Heidi. I think this was the end of your recorded presentation, and now I'll hand on the floor to Lisa for her complementary comments and for her slide here. Over to you. Thank you.
All right. Are you able to see my slide?
Yeah, can you put it in? Yeah, you need to put it in presentation mode, please. Okay.
Yeah, no problem. So hi, thank you for having me today. Very nice to follow on Heidi's presentation. So I'm currently the research director for the new initiative Global Listening Project, along with Heidi. I'm also co-director for Vaccine Confidence Project at London School of Hygiene and Tropical Medicine. I'm leading a behavioral and digital innovations group that based off in Asia. That's where I am right now. So hi from Asia. So for the work that I've been doing in the past, actually more than a decade now, since 2008, my work has been centering around public health emergency preparedness. I have a behavior and communication background. And so we have been looking at this in the pandemic context. Since 2008, unfortunately, we have been going through several large-scale disasters, public health disasters. And then if we are looking, just counting the outbreaks, we have been through H1N1 in 2010, MERS after that, and then the most recently COVID. So we have, however, from these experiences, we see some common challenges. Trust has always been the issue. Misinformation has been always the issue. And how do we learn from it? And I think all these challenges, they were shown and detected at the time. However, I will echo what the other presenters have just said, that all these lessons that have been shared and even documented, however, it seems to not being able to translate into the following action. So that in the COVID, because I think this pandemic is a lot longer and a lot more like impactful on a global scale, then we definitely see the agony among the people, that we see this at a much extensive scale. So I think three highlights I would like to say that we noticed during COVID is that we see the eroded trust in government. People do not trust the government, and that has an impact on their willingness to accept the guidance, willingness to follow. We also see the development of technology, and then we also see the trust and mistrust and distrust in technology. For example, the social media impact. We started to see the trend and the impact of social media back in 2010 when H1N1 happened, and then when MERS happened. But then actually during COVID, we definitely see a lot of influence, and that leads to trust or in factual statement, but also trust, unfortunately, in misinformation. And that has compromise our response effort, and especially in our own work, we see that in the eroded trust in vaccine confidence, unfortunately. And then, so I think that for our work, just to summarize before I pass on to a next speaker, is that to highlight the Global Listening Project, we are taking a social ecological approach. So what we are looking at is the individual and the community and the society. They are interlinked, and then we need to somehow work together. And this approach, we need to be able, with this interconnectivity, that we'll be able to hopefully enhance preparedness. We need to strengthen the preparedness capacity through trust building that lead to resilience, and then a systemic response. So that's a summary of my past decade's work, and then moving forward to our Global Listening Project. Thank you. Over to the next speaker.
Thank you very much, Lisa, for this very useful addition to Heidi's presentation. We'll go back to the issue of trust. And so to close our panel here, we have Professor Anna Antich, who's Professor of European History and Medical Humanities at Copenhagen University. She's a social and cultural historian of psychiatry and related discipline, and whose research focuses mainly on the history of modern Europe and its global connections. And she's the PI of an ERC project entitled Decolonizing Madness, and also a project funded by Novo Nordisk on COVID-19 and mental health, the importance of cultural context. So thank you, Anna, for joining us. Over to you. You don't have slides, as somebody was telling me either you can have something to say or maybe instead show a PowerPoint. We'll have the first option. And over to you. Thank you.
Thank you. I'm sure that's not quite the case. I think it's more about disciplinary differences. I think now I'm moving more in the direction of humanities, where we don't always have slides, but I'll try my best. Thank you very much, and good afternoon from Copenhagen. So I will talk very briefly about illness, politics, and society, and understanding pandemics beyond the clinical framework. Right? I'm focusing on some of the questions. I have mostly questions and not answers, not so many answers, about how humanities and social sciences can help us understand what Annemie was talking about, this whole societal response, inclusive, holistic societal response to and experience of the pandemic. So I'll talk about three different things. And the first one is about political framings of the importance of political narratives of the pandemics in different parts of the world and how they impacted the behavior of people, but also policy making and health outcomes. The second question is about the broader contexts of the pandemic in each particular community, and how different forms of distress and different forms of political and economic and social crisis overlapped and reshaped the pandemic in different parts of the world. And finally, I want to talk a little bit about mental health and well-being, and in line with the project that I'm leading here about COVID and mental health in specific cultural and social contexts. So in terms of the political narratives of the pandemic, I think the contribution of historians and anthropologists and other humanities scholars would be to investigate how both officials and popular narratives place the pandemic and its associated threats in specific political contexts, and use the pandemic for specific political purposes. And this was quite crucial for the variety of both health and both clinical and non-clinical outcomes. So some of the questions that I have is how were specific political themes, symbols, concepts utilized to make sense of the pandemic? How have different groups, both inside and outside official governments, relied on a variety of historical comparisons, historical parallels to promote, or historical traumas, to promote or discredit certain policies and approaches, and to exert pressure to promote their own requests and interests? Finally, how has the politicization of the pandemic played out across the political spectrum, and what's the difference between left-wing and right-wing politics in this regard? So these different approaches to the political framing of the pandemic and similar major health crises have had a major impact on behavior of different sections of the population, and most importantly, their responses to the pandemic and to the state policies, in particular their compliance with the healthcare professionals' advice, instructions, and laws. But they have also fundamentally shaped the very policies as they were created, developed, and implemented, and as of course, as I said many times, the outcomes. The importance of political context and messages could not be overemphasized, right? The political narratives of the pandemic's outbreak, course, and outcomes have been formulated and revised throughout this period, and they have fundamentally shape the very experience of health challenges. So the question is, how can we begin to understand this influence, and how can we explain why particular political narratives or framings or approaches emerged, and why they became more impactful than others? And there are lots of examples here that come from my own research and also from the research of the colleagues on the project that I'm leading. So in the case of the UK, you had a large number of comparisons of the pandemic in health journals, in medical journals as well, of the pandemic with the Blitz in the UK, so that the focus on the sort of the beginning of the Second World War, the focus on resilience, of not isolating or scaring the population too much, on this political symbolic that served to justify lax lockdown rules in the beginning of the pandemic. In my colleague Anna Iskra, for instance, Dr. Anna Iskra, who's doing research, anthropological research in China, has written about the focus on positive outlook and enthusiastic militaristic rhetoric in China in the face of increasing restrictions and state violence, and then also looked at political resistance to both the regime and the pandemic rules and instructions and policies in the form of the concept of political depression there. In increasingly authoritarian Central and around East European states, we witnessed the emergence of official government narratives which infantilize the general population, indicating that it didn't know or understand how to take care of itself, so that the state would have to intervene heavily as a parental state, right? And of course, we had an example of popular narratives or resistance narratives of people outside, of groups outside the governments, which focus on the historical unreliability of governments and their policies, right? Exhibiting mistrust, as we heard before, in the government's benevolence, right? So two issues I think that are really important here, and one is the supreme importance of collective memories in specific communities, historical memories, how they're used in political framing. This is obviously, as we heard, relevant for vaccine uptake and compliance, right? We have memories in many cases of abusive state policies and coercion in the medical sphere. So it's worth thinking about how to engage with such negative memories and narratives, and which link health interventions to abuse, experimentation, dehumanization, or simply frame health emergencies as an opportunity for the state to increase its political control and surveillance and nothing else. And the other really important issue, which has been raised before, is this mistrust in the state, mistrust in the state's benevolence, but also sometimes mistrust in the state's competence and credibility to administer responsible health measures. The second issue that I've been thinking about is about the pandemics that don't occur, how pandemics don't occur in medical and clinical vacuums, right? And how there are different forms of distress which have interacted during the pandemic, and how that can be addressed, how we can deal with that complexity. With regard to a variety of political, social, and economic crises occurring in parallel with the pandemic. So a variety of political, social, and economic crises affected different parts of the world and different sections of the population. So we had political violence and oppression, outbreak of political protests, outbreak of war, forced migration, as well as more kind of insidious and hidden chronic socioeconomic challenges such as extreme poverty, discrimination, racism, lack of access to basic services. So some of these distresses, some of these forms of distress emerged abruptly in the course of the pandemic, others have been more structural, but in both cases, competing political and socioeconomic challenges have posed serious difficulties for pandemic planning, prevention, and communication, and often pushed pandemic-related planning and communication into the background. So how do we conceptualize these parallel crises, and how can these complex interactions be understood, analyzed, and expressed in effective policy making? Is this one of the core questions. And something that's really important to me, such alternative political and socioeconomic factors that overlapped with the pandemic and made the pandemic less relevant or exacerbated the pandemic, they meant that the pandemic had a fundamentally different nature in different societies. A vulnerable population experienced this complex of medical and socio-political challenges in different ways, and COVID-19 therefore meant very different things and meant very different experiences in different social and cultural settings, even though we have this assumption about universality and universal conditions, right? And so the pandemic has not been universal, not has it been assigned a universal meaning and impact and narrative. And so how can these complex economic and political forms of suffering be addressed, especially in the context of vulnerable communities? And I'm probably running out of time. So the final issue is about mental health and well-being. And so how to acknowledge the role of specific political and socio-cultural contexts in the development of mental distress during the pandemic. Again, it's very important to move, I think, beyond this dominant universalizing discourses on mental health during the pandemic, right? Acknowledge the importance of cultural and social and political diversity, which shapes suffering and well-being and ideas of resilience, right, in fundamental ways. And I think for this, we need to incorporate some important propositions and frameworks and methodologies offered by both cross-cultural psychiatry in the decades before the pandemic, work them better into the current research, and also rely much more on some crucial anthropological and historical insights, right? And so the pandemic's negative effects on the mental health of different populations have been widely and remain widely discussed, and there are a variety of different competing analyses and and arguments, but it's important, as I said, to pay more sustained attention to the complex relationship between specific socio-cultural and political contexts and experiences of mental illness, even in the context of the pandemic, which appears to create these universal, supposedly universal conditions around the world. Because the pandemic experience has been radically different in different settings or for different social and cultural groups. So how can humanities again and social sciences help us conceptualize pandemic-related suffering and resilience in such a way as to take into account the effect of this extreme health crisis on everyday lives and well-being in specific communities, and to design culturally and socially tailored and sensitive policies. So how can we think of mental disorders and illnesses and health and resilience in a carefully contextualized way, taking into consideration not only clinical voices and perspective and experiences, but a wide variety of actors, perspectives, and contributions beyond the medical frame. So I'll end here. Thank you.
Thank you very much, Anna, for your contribution. So now we'll open for questions. Let me just remind all the audience that you can write down your questions in the Q&A section. In the meantime, we'll have barely 15 minutes. So I will ask our panelists to turn on your cameras so that everybody can see you. And let me ask a first question to Annemieke. Of course, your presentation built very much on showing the need of this whole of society approach to pandemic preparedness, but how we could link the different networks and the different societies in this process, and among others, networks like EGHRIN.
Yeah, thank you. Thank you for this question.
I will ask very brief questions so we can take questions from the public also.
Yeah, so I think it's important to link across networks and society, because these networks and societies are usually disciplinary organized, and we need the different disciplines to talk to each other. What could help is, if we do that, is that it would create awareness among the members of the different networks of the complexity of the problem, and also learning over the networks, understanding the point of view of the other disciplines, because there's not just one single view on pandemic preparedness. What we could also do is design educational tracks together, where we could roll out a whole of society educational concept on threats, emergencies, and building a better future in general. So not only for pandemic preparedness. And connecting across these disciplinary networks would also stimulate innovative research. We could have specific topic-related calls where we can join people from the different networks to address these problems like pandemic preparedness, but also inequality, poverty, human rights, so that we can start to actually do a transdisciplinary approach to pandemic preparedness. So I'm keeping it brief.
Thank you, Annemieke. So moving on to Lisa's presentation, where trust was at the core, Lisa's and Heidi's presentation, where trust and interconnectedness regarding on the process of building trust. At which level, a question for you, Lisa, at which level of society would coordination and somehow the strengthening of this connectivity for a whole of society approach be most needed?
Thank you for the question. So from our work, we've seen that it's very important to at least to focus on two levels approach, which will be the community level and the systemic level. And this is usually done by effective communication through trustworthy building effort. But then I think I also want to echo on Annemiek's point. I think that there are we have seen that in the past, there were so what is important could be to connect with existing resources, existing network community. So these communities are actually quite effective during the response to disasters. Usually they were already in existence prior to the disaster. It could be through like a religious community. It could be already like some professional organizations. They were ready to mobilize during a pandemic, but then I think they will need some help in connecting with one another during a crisis. So I think that reactivated or nurturing them will be quite important. And usually they are our great partners when it comes to building trust, to building resilience, and then to build interagency like connectivity. So this usually is quite, they already have existing initiative manpower, but then what we could do is to listen to them and empower them. So that would be done more organically. The other more a systemic approach, what we are looking at is usually requires some government investment. So it could be done through grant, it could be done through some initiative by research institutions or by government funded. Because what it takes usually in the past, what we've seen is that, for example, we organize more of a regional or local drills and exercises. So the initiative was to look at the evaluation of preparedness level, and then through that process, we allow some training activities, educational activities, and then, but at the same time, it will also allow cross-agency communication. So we allow, for example, some hospitals to be working together with police department, fire department, and researchers, so that we know each other prior to the pandemic. And then so I think that what we were saying is that we don't exchange business cards when there's a disaster. So we do this prior to a disaster. So that will allow us to be more strengthened in our trust, mutual trust, but then also strengthened in our preparedness level for resilience. So so that's my 2 seconds. Thank you.
Thank you very much, Lisa. Now on to you, a question for Anna, linking with a little bit your thinking or your contributions on the political framing, on the importance of the collective memories and the implications for mental health from a cross-cultural perspective. And what this shows is that humanities and social science research at large have a role to play, and they have not always been considered in the responses to the pandemic and to the preparedness. So how do you think these areas of knowledge, humanities, social science, and related research knowledge areas can enhance the effectiveness of the policies that are needed and that you briefly outlined? Over to you.
Thank you. So as a historian, I think it's very important to study how historical context, and as you said, these narratives and these experiences, historical experiences, or the way they are framed and told in memories, and how they shape the process of meaning making, and how then that process of the meaning making for the population at large, but also for governments and policymakers, right? How that process of assigning meaning and assigning interpretation to the pandemic, how that can actually then affect health policies, health results, the behavior of different groups of people, right? And so kind of moving away from the universality and going, as was mentioned before by other speakers, into the local and regional, and also studying with regard to humanities research and social sciences, how the narratives and meanings are created and assigned, and how the pandemic is made sense of for different populations, because without that there's I think it's difficult to understand responses and behavior. I think humanities can also help us understand how historical narratives and political ideology then work into shaping these framings and experiences, illness experiences, no, in the pandemic. And they can also help us understand how pandemics become a site for discussing political and socioeconomic, right, non-clinical, non-medical concerns and issues, and how they can also become sites for mobilizing particular populations for specific political goals. So I think understanding the process of meaning making, the role of historical narratives, the role of political ideology, and how pandemics become instrumentalized and mobilized for different political and social issues. I think that is really important to take into consideration when developing policies for specific communities and then societies.
Thank you very much. So we have one question in the chat from Wouter Arrazola de Oñate. I'll just read it, and it's to any of you or to more than all of you. How can the influence of disproportionately powerful and wealthy commercial players be balanced, especially in the framing of a TRIPS waiver, the role of the EU, Bill Gates, member states, close to big pharma, and related with this, the vaccine apartheid behavior of the world was a disgrace for humanity. This is Walter's comment. So do you want to comment on this, please, or respond? Annemieke, it's you.
I think this is a very important question, and I think we should all three have a small comment on it. So let me start. I think we have to address this, but from a biomedical point of view, I don't know how we can do that. I think it needs a whole of society approach to address this question. And you can see that some of the biomedical people are entering into this field. If you saw what Túlio de Oliveira did, he was actually actively on social media showing the disgrace to the world of the vaccine apartheid, as you said. So I think we can make a difference from the biomedical field by stepping out of our biomedical comfort zone into this more political zone. And I'm very reluctant to do that myself. And I'm happy that there are some that are doing that. It's just you get a barrage of all kinds of social media over you. So, but I think yes, maybe I'll leave it to others to answer further.
So Lisa, Anna, Lisa, do you want to expand on this very briefly, because we still have one question in the chat, and then we'll close.
So through our global listening approach and the vaccine competence projects, we definitely pick it up. This is a very real and frontline issues that Walter brought up. So we see that this connection to big pharma, and then unfortunately that may or may not be avoidable. It really leads to misinformation that being circulated on social media and also in person in the community. That I don't know, like I even have people circling around me that brought up the issue. They started to question the efficacy of this, the readiness of the vaccine, even the need of this vaccine at all. So we see that, and then they see that it also open the window and space for conspiracy. And so therefore we definitely see the challenge that this has brought to public health like professionals when we trying to communicate importance of vaccines. And then it eroded actually sometimes our credibility, and then also definitely government's credibility when they were trying to roll out these vaccines. And we see this again and again, and then definitely during COVID, that was pretty like, it's a phenomenon that we detected through our work. And so if I would like to, we don't really have a solution, otherwise we don't have the problem right now. But then I think I would say that being able to work with the community, have trusted messenger that where we could build partnership upon, knowing firsthand where this hesitancy comes from, where this misinformation comes from, then and the concerns. And I think one key thing is to acknowledge that the concern is real. Like, we are not discrediting any of these concerns that are being raised in the community. And then the question that they pose about the connection between with the big pharma, this is all real. So I think being able to address that, acknowledge that, but then at the same time having a communication strategy, being allow people to see the importance of vaccine and how it still bring benefits to individual and the community will be quite important. So over to
thank you, Lisa. So let me just bring the last question in the chat from Cesar de Souza and ask you, Anna, a comment on this. Basically, it has to do with whether the response needs to be global or it's better to do it at multiple local levels. So somehow in a local, if I may say so, approach. Can you comment on that, Anna? And then I'll just give the final comments.
I think, yeah, this is very difficult. I think, I think both. I guess. I mean, I think as Annemie and Lisa were just was saying, I think this particular phenomenon, right, that contributes to the spread of conspiracy theories, but also to sort of basic distrust in both the states, but also like the healthcare, the profession, right, the biomedical profession, right. It really reinforces this idea that different communities have experienced very different pandemics, right, and they've dealt with completely different levels of anxiety and fear and uncertainty. So that has to be addressed, I think, on a local level, in local campaigning and redefinition of the core values, no, of the pandemic and intervention. But also, I think without some sort of massive global intervention and change, this is probably going to have limited consequences. So sorry.
No, thank you very much. I think it's been a very interesting conversation, meeting a little bit the objectives that we had for this webinar, and which I stated in my introduction, which is looking at preparedness a little bit beyond the usual approaches, and bringing in the picture this whole of society approach from three very relevant or four very relevant contributions. So I think definitely this meets our objectives and the objectives of EGHRIN in trying to expand the discussion around complexity of preparedness, around trust and distrust, and some of the drivers of this, of the importance, of course, of the context, both political, cultural, social, and so on. And of course, trying to move forward. And basically, this is what we will try to do in terms of from our networks. We talked about enhancing connectivity, and this is precisely what EGHRIN wants to do at different levels. And in this case, trying to bring, go a little bit beyond our comfort zone, and in this case, largely academic comfort zone, to bring some of these thoughts and some of this experience to a broader debate, to a broader discussion in the European context, but also with our partners and our many collaborators throughout in the global south and throughout the world. So thank you very much to our four panelists for your contribution. Thank you very much to Alberto, who's at the Secretariat, Alberto Rocamora. If any of you want to have more information or want to make any added suggestions to what this was debated and to our, as I was saying earlier, our position note from EGHRIN, please contact him. And this webinar, which has been recorded, will be available in a few days, will be uploaded at our website. So thank you very much to all panelists. Thank you very much to all participants for your contributions, and hope to see you in a couple of months with a new webinar. And it's still not clear what it will be, but it will be another opportunity to share with all of you some of our concerns and some of our aspirations at the European Global Health Research Institute Network with all our colleagues. So thank you very much, and see you soon. Bye-bye.